All right. Welcome, everyone. We're so excited to have you here today for the new installment of our Mood and Menopause series, Bring on the Heat. And today we're going to be talking about changes in emotion over the transition to menopause. A few housekeeping things here at the outset, just so you all are aware. You can put in questions or comments in the chat. And when you do that, everyone in attendance here will be able to see your comment or question. If you want to send questions privately to Dr. Nathan and me, you can do that in using the Q&A button on your Zoom webinar. And so those will not be visible to the whole group and just to Dr. Nathan and myself. There are going to be some audience participation moments here today. And we're trying to sort this out as we go along, because part of our goal in doing these seminars is to also build community for folks out there who have symptoms, who want more information, but I think it's helpful for you all to be able to connect with one another too. So there will be more opportunities to do that in future sessions, both the virtual ones where we may open it up to small group discussions and ways for you to connect with one another, but also in-person sessions that we have planned coming up in the spring semester. So stay tuned for that, because I think part of our goal here is really to help build community, and we're excited to be able to do that. Today, it will be a little bit clunky because we're going to do it through the chat. Unfortunately, there's no way in this webinar format for you all to see one another, or for us to see you, which always feels a little awkward, like I'm kind of on a radio call-in show or something. So what we're going to do, we're going to change that in future sessions. But for today, where there's audience participation, we'll ask you to respond to questions in the chat. So to get started, my name is Crystal Schiller. I'm a clinical psychologist at UNC in the Department of Psychiatry. And my colleague, Dr. Margo Nathan, is a psychiatrist also in the Department of Psychiatry. We are both clinicians. We have a menopause clinic at UNC where we see patients. And we're both researchers, and we're going to talk a little bit about some of the research that we have going on today. We hopefully won't bore you too much with the details of it, but just hopefully present the most relevant or interesting parts. So there'll be opportunities for questions along the way. And as I mentioned, for those who've just joined, if you put your questions in the chat, everyone here will be able to see them. And if you put them in the Q&A, then just Dr. Nathan and I will be able to see them. You can also change your screen name if you'd like. I notice many of you have identified yourselves with first and last name. And when you put things in the chat, your first and last name will appear there unless you change your screen name in advance of that. All right. Great. I think that's all the housekeeping. Margo, is there anything you wanted to say by way of introduction?
No, just to echo Crystal's comments, I'm Margo Nathan. I'm a reproductive psychiatrist at UNC, and as she mentioned, have this interest in menopause, both clinically and through research. And, just a huge welcome to everyone who's joined us today. And we're, really excited that you're interested in learning more. And, we really want to be a resource to you. So welcome, and we hope you learn.
Okay. So to start, this is our first interactive opportunity. So would you please put in the chat what you're hoping to get out of today's session? I'll give you a few minutes to do that. So thanks for folks for putting stuff in the chat. Yeah, and these are really common reasons for attending sessions like this. So to know what's normal, what's not normal, just sort of validation that what you're going through is common. Yeah, more information to understand what's going on or what you're going through. Anxiety, more information about anxiety or help for anxiety related to menopause is great. We are going to cover some of that today. Yep, tips for managing symptoms, and yeah, evidence-based information. That's really the reason that we're here. There's so much bad information out there, and from wellness influencers, diet companies, people trying to sell you expensive tests. And so we're here to help combat some of that information, help you learn more about good treatments, what the symptoms are, how you can manage them effectively. And we can also provide information about hormone therapy. That's part of what we have planned. We're going to make some brief remarks today, hopefully not put you to sleep. And then there'll be lots of opportunities for Q&A today as well. So please, as questions come up, go ahead and put them in the Q&A and we will address them, or you can put them in the chat, as I mentioned. So thank you. And we really want this to be interactive, even though it's like this weird webinar format. So please feel free to put comments and questions in there. Great. Okay. So I don't think it will come as a surprise to anyone here today that emotions change in the transition to menopause. So the transition to menopause is a period of time when hormones are fluctuating a lot. So if you attended our last webinar, you heard a lot about this. But in case you didn't attend our last webinar, we wanted you to know that we want to define some of these terms. So menopause is the period of time after which you haven't had a menstrual period for at least 1 year. So that 1 year mark is when you're said to have entered menopause. Prior to that, your hormones are sort of all over the place and on average declining. And you may be having really irregular periods. So in the beginning, they come more frequently, they're heavier, and then over time, they kind of space out, and you may skip periods or only have them like randomly and sporadically. Some of our patients have them and like will go for months without a period, and then they'll bleed for like 3 weeks straight. And that is a common part of this menopause transition. So we call that period of time before you've gone a year without a menstrual period, the menopause transition or the perimenopause. And so you'll hear us use both of those terms today. So many women experience emotional changes during this transition to menopause. A lot of people don't realize that depression is actually 14 times more common in this transition to menopause. 50% of women experience symptoms of depression during this time. And then about 10% receive or could receive a formal diagnosis of depression. And those with a history of depression are actually at highest risk for experiencing mood changes during this time. So for those of you who had questions of whether this is normal or not normal, it actually is common and really normative to experience changes in mood during this time. All right. So next, I'm going to turn it over to Dr. Nathan to talk about some of these common symptoms that people experience in the transition to menopause, because she's doing a study on this right now.
So let me also just kind of add on to what Dr. Schiller said, that this is really common. So we sort of quoted 50%, but there are some studies that show that even up to 60 or 70% of women will have some symptoms. So that means really the majority will have some of these symptoms that we're going to discuss today. So just to kind of highlight again and again how common this really is. We've said depression, but there's really a range of symptoms, distressing symptoms that women can experience associated with these hormone fluctuations. They can have sad mood, but not only sad mood. They may experience irritability, change in interests, not wanting to do sort of our favorite things, fatigue or not having enough energy, trouble with sleep. And we're going to talk a little bit more about that sort of later in the course of this talk, what that sort of sleep disturbance looks like. But just to, again, sort of highlight over and over how common it is. There may be changes in appetite, anxiety, higher levels of stress, panic attacks, and also sort of memory changes, sometimes challenges with attention, feeling like we're not as cognitively sharp as we typically are. I think this is really important to kind of highlight the spectrum of symptoms that women describe, because oftentimes, again, we say depression or depressed mood, and that's not always a term that women connect with because they may be having more anxiety, sleep changes, these cognitive symptoms, and so forth. So there really is this kind of broad spectrum of symptoms that can happen during this transition.
Great. And I think one of the things I want to highlight here is that irritability is a really common symptom that people don't often talk about. And so irritability, I think most of us know what it means. It just means sort of this lower threshold to experience anger. And you know, in our society, women are not supposed to be angry. We're sort of punished for being angry. And so this experience can feel really terrible because it's, you know, different from the way a person normally feels. And then there's so much societal pressure not to feel that way. And so I try to incorporate this into all of the, you know, new sessions that I have with new patients, just to make sure that people are aware that this is a really common experience and that we do have good treatments for it in case it is something that is really bothersome. Right.
So similar to changes in mood, we also commonly see changes in sleep during this time. So some of our research has shown that about 30 to 60% of women will have some disturbed sleep during this time. So again, a huge, huge number. And we all know how important sleep is to how we function. So this is one of the most common causes of just distress and feeling of, you know, functional impairment during this time. Historically, we used to think that these sleep challenges were only associated with hot flashes, waking women up at night. But now we know that that's not the only culprit here. Sometimes women are just waking up more, even if they don't really have hot flashes or temperature changes. We also see that menopause is a time that tends to coincide with just more sleep disorders in general. So sleep apnea, restless leg symptoms also tend to be more prevalent because of these hormone shifts. So it's always important to kind of think about those other potential culprits for why we're not sleeping, thyroid changes, and so forth. More often than not, it is a pattern of what we call sleep fragmentation. So what that often means is a woman's able to fall asleep, but then she wakes up, is awake for a period of time, can't go back to sleep, falls asleep for about an hour or two, wakes up again, can't go back to sleep. There's sort of this like newborn almost pattern of sleep that's occurring again. So it's a little bit different than just trouble falling asleep at the start of the night. And part of why this is important is how we think about treating it is a little bit different, because we want to promote sleep consolidation or giving women that kind of uninterrupted sleep. And again, just to kind of acknowledge that these sleep difficulties are not benign and can be a major sort of impact on quality of life and so forth. Hot flashes or vasomotor symptoms, sometimes called night sweats, or really just temperature dysregulation. Some women describe kind of classic hot flashes, which can be sort of this trunk and face like redness and like feeling of warmth that comes on suddenly. Sometimes it actually has an anxious aura with it. Other women experience temperature dysregulation. They feel cold when they shouldn't feel cold, then they feel warm in a way that doesn't make sense. But again, it just feels like your temperature control is kind of like haywire, for lack of a better way of describing it. So again, one of the kind of more common sets of symptoms that happen with menopause, and another major impact on quality of life and function. About 60% of women will have hot flashes or sort of temperature disturbance. And then almost like a third of women will have fairly severe hot flashes. So they may have like 6 or more a day, even lasting kind of years after that last period. And as I mentioned, hot flashes can be associated with higher levels of stress and anxiety and irritability. So thinking about sort of who's at risk for developing not just emotional symptoms, but even sleep disturbance and hot flashes in general. So history of sensitivity to other times in life with hormone shifts. So if you're someone who's had mood symptoms around your menstrual cycles, kind of before your periods became irregular, or who had symptoms during puberty or in relation to pregnancy, that's something that gives us some pause or kind of makes us sort of think this is someone who may be at risk for developing mood symptoms related to menopause as well. Complex medical issues, so thyroid issues, other kinds of medical issues, diabetes, cardiac issues that can develop later in life have an association. Just to acknowledge that higher levels of stress and feeling of sort of loss of support or life changes that can be stressful are definitely associated with developing some of these mood symptoms. And again, sort of the sleep and hot flashes and so forth. And just to kind of say, often these things are intertwined, and it's very hard to kind of parse out sort of what the one culprit is or the one sort of worst symptom. They often go hand in hand. And the good news there is that a lot of our treatments actually tackle all of these problems simultaneously. So there's a lot of good solutions, together. So we talked a little bit about sort of what I'll call big D depression, which is about that 10 to 15%. But that's not the only illness that can happen during this time. There's also, just as Dr. Schiller mentioned, what I would call sort of this subsyndromal set of depressive symptoms, which is that kind of 40 to 60% of women, just higher levels of distress and stress, as well as anxiety. More stress in response to life changes. So menopause is often a time that coincides with potentially kids being in different phases of their life, career changes, maybe being in that sandwich generation where you're caring for younger ones as well as older ones, other types of kind of life stressors. So we want to kind of keep that in mind when we're thinking about, potential etiologies for some of these symptoms. Crystal, do you have anything to add there?
No, I mean, I think there's a complex set of factors that can contribute to any kind of symptoms or changes in emotion that happen during this time. And so that can be a benefit of working with a psychologist or a psychiatrist to kind of sort out like what is causing the symptoms, like what's causing me to feel this way, and how can we best address it so that you can have sort of an individualized or targeted plan. And, in the absence of that, for folks who may be experiencing more mild symptoms, we hope that the information we're providing today will help you kind of better understand what may be going on.
And just to add one more thing, I think sometimes we're told that this is just kind of a fact of life. It's just something we have to deal with. And part of why we're here today is because there are treatments, even if you're not having sort of the most severe depression, there are ways to kind of help all of us feel better during this transition.
And function better too. So I know that, it goes beyond just like feeling kind of stressed or potentially even miserable with some of these symptoms, but it impacts our ability to work and think and even just get through each day. And so I think if you're in a place where things are just feeling a lot harder, or your relationships are changing because you're feeling like I'd rather just like sit on the couch, which is what many of our patients tell us. There are things that we can definitely do to help with that. So one question that you may have is like, why does this happen? It seems so unfair and unfortunate. And so that's a question that I have attempted to tackle in my research over the past, I don't know, 10 to 15 years. And I can tell you a little bit about what we have learned. So first, and I don't want to make this sound like hormones are always bad. They're not. Our hormones, especially our reproductive hormones, which are estrogen and progesterone. Estradiol is the one that I have shown here. That's a form of estrogen. These two hormones regulate our brain and behavior, and they have to do that in order for us and for the human species to survive. So hormones regulate our eating behaviors, our reproductive or sexual behaviors, as well as our maternal behaviors, among many other things as well. And so when our hormones start changing, really dramatically during this menopause transition, all of these things change. And so you may be experiencing that. And so how do we know that that's the case? There have been a lot of studies done, and these are like technical science graphs here, but I think it's important for you all to have this information. So as we go through the menopause transition, starting here before menopause and then advancing through to after menopause, that we see the incidence of depression, the number of people who get depressed goes way up right here in the late transition to menopause. So this is a time during menopause when your periods are coming, but very irregularly. So you may have had no periods in the last 2 months, but you've still had a period in the last year. That's how this late menopause transition is defined, and rates of depression go way up during that time. So what's happening with estrogen during that period of time? So during this late menopause transition, when depression goes up, we see that estrogen on average is going way down. And so this has led many people to think that that withdrawal of estrogen is what triggers depression for so many people. And then what we also see is that when you give people estrogen during that late menopause transition, it actually reverses those depression symptoms. And so that really was the impetus for my program of research in trying to understand why or how estrogen exerts its effects on the brain and mood, and also how it can act as sort of a rapid antidepressant. More recent research by some of my colleagues has shown that it's not just that drop in estrogen, but it's actually the extreme changes in estrogen day to day that seem to contribute to depression. So you can see here, one day your hormones may be up really high, the next day they're low. Over time, it's just sort of like this jaggedy line. There are periods when they're down fairly low, but then whoops, you're back up on the roller coaster again. And so that kind of variability in hormones day to day is thought to really drive those changes in mood. So that led me to start examining this using brain imaging studies. And specifically, the tool that I had been using up until our current study is called MRI, so magnetic resonance imaging. And it allows us to take pictures of the brain that look kind of like this. And we can see how brain activity actually changes before and after giving estrogen. And we can look at with estrogen change and progesterone change, like how your brain responds. So one of the studies we've completed showed that when we gave women estrogen, just in a patch form for 3 weeks, we're able to show rapid reduction in depression symptoms, and really across the board of all those different symptoms that Margo or Dr. Nathan mentioned earlier. So we see a reduction in the symptom called anhedonia, which is a loss of interest or pleasure in things that you usually enjoy, a rapid reduction in sadness. And again, this is just in 1 week, we see a pretty significant drop in feelings of sadness. And you can see the biggest change here in irritability. And so a lot of people experience a lot of relief with estrogen and that irritability symptom that can be so troubling. So this relates back to the hormone variability that I described before, because we found that the people who had, once we started giving them estrogen, the people who had the lowest levels of variability in hormones day to day after we gave them the estrogen, then they had the lowest level of depression symptoms. And the people who continued to have more variability in hormones, even after treating them with estrogen, they had higher levels of depression symptoms. So that's more evidence that this change in hormones day to day is the thing that really drives depression. So now I'm going to show you what happens to your brain on estrogen. So you're across all of our participants, whether they had depression or no depression during this transition to menopause, treatment with estrogen reduced activity in several regions of the brain. And so we think of this as sort of like a calming effect on the brain. And then what we also see is that people with depression and not people without depression had this specific change in this brain region. This is the front of your brain, and this is the outer surface. We see that estrogen reduced activity. We think of it as overactivity in this part of your brain that's responsible for helping regulate emotions in people with depression. And so estrogen treatment really corrected that in our participants. We also see that estrogen reduced some connections between the part of your brain that's responsible for producing emotions. That's called the amygdala. It's like deep in the center of your brain, and it becomes really active with emotion stimuli. So frustration or sadness or irritability, like this part of your brain is super active in responding to those kinds of stimuli. And then the front part of your brain basically tells that part to quiet down, to say, okay, yes, this is frustrating, but we can get through it. Or I can make a plan. And when the amygdala is really active, the front part of the brain really has to be on high alert and respond. And so that connection grows really strong. And estrogen actually calmed that connection down. And so that's something that we're trying to understand better so that we can develop even newer and better treatments for depression during this time. So that gets us to, okay, that's fine. I understand what's happening in the brain, but like, how does this translate to what we should do in response to this? So I'm going to start first by talking about behavioral things that we can do. And then I will transition and let Dr. Nathan describe some of the medications that seem to be helpful.
Dr. Schiller, can I just add one more thing to what you just said? So I think we talked a lot about kind of fluctuating estrogen as part of like normal menopause. And we know that there's other ways women enter menopause through medications, surgery, and so forth. And a lot of these principles still hold true, that it is literally the change in estrogen that is associated with a lot of these symptoms. And so because of that, we can sort of apply some of those concepts that Dr. Schiller mentioned to these other scenarios, which helps inform treatment. And I wanted to mention this because I see in the chat that a few people asked about treatments when hormones are not an option. And the good news is there's still a lot of really good options that we'll hit on today.
Right. And so one of the ways that I think about this is whether you're going through natural menopause or whether you've had surgical menopause where your ovaries were removed. As Dr. Nathan mentioned, that change in hormones can trigger new emotions to come up. And some people sort of get stuck in that emotional state. And so even though, in the case of surgical menopause, eventually your hormone levels are depleted and stable, that doesn't mean that your mood necessarily returns to normal, or normal for you. And so it can feel like, well, that change in hormones triggered a depression or anxiety, and then you just sort of get stuck there. And that's where some of these treatments can be helpful. And so Dr. Nathan mentioned earlier stress and mood. And so the research really shows that stress amplifies the effects of hormones on mood. And so the good news there is that not that we're all like screwed because everyone has stress, but that stress is actually a modifiable thing, and behavior therapy in particular can target stress. We know that chronic stress, so ongoing stress, like the stress that we all experienced early in the pandemic, increases the risk for depression, which is why we saw depression rates go skyrocketing during the pandemic. Depression also reduces the brain's response to positive things like rewards or social connection. It just doesn't feel as pleasurable or exciting as it once did. But we have good treatments for that, actually. So behavior therapy is both effective and now more accessible than ever before, because the pandemic has caused changes in the way that treatment is delivered. So in our clinic, we use a lot of different kinds of behavior therapies. Today, I'm going to talk about behavioral activation therapy, to kind of just explain what it is, because a lot of people are reluctant to sign up for therapy because not knowing like what the heck we're going to ask you to do. On TV, if you see therapy, I think a good example is like The Sopranos or a lot of other shows on TV where it's sort of open-ended, and the patient sort of lays down on a couch and like just talks about whatever comes to mind, and they may be encouraged to like explore their childhood. And that's not the kind of thing that we do in behavioral activation therapy. It's really focused on specific problems that people are having now. And we may ask questions about your childhood, but we're more interested in how your life experiences are contributing to the way you're feeling today, and what we can do to help you feel better here and now. So we use behavioral activation therapy to increase motivation, reduce depression, and research has really shown that behavioral activation therapy is at least as effective as antidepressant medications. And so that's great because it means that there's another tool for folks to use. And we see that often the combination of medication and therapy works better than either treatment alone. And behavioral activation therapy really works by helping people engage more in their lives. And so the three domains that we really work on are ways of experiencing pleasure day to day, helping reinforce or make new social connections, and celebrate accomplishments, because during this time of life, it can feel like you're just kind of going through the motions, that you are established in your career or with your families, and you're doing all the things, and yet it's sort of a thankless kind of job. And so taking time to slow down and really celebrate the things you're doing can help a tremendous amount. I want to quickly say that during the pandemic, things really moved online. So that's when I was saying therapy is more accessible now than ever before, because now insurance companies pay for virtual therapy, meaning that you can connect with a therapist online and not ever have to go into an office anywhere. So that makes it much more feasible for most people to do on a weekly or bi-weekly basis. And we did some research that I should have added was published earlier this year that showed that virtual treatment, whether it's face-to-face with a therapist on a computer or on the internet or through an app, virtual treatment is 10 times better than no treatment at all for reducing depression symptoms and achieving remission from depression. And that virtual treatment is 2 times better than regular check-ins with a doctor. And it actually works as well as face-to-face therapy in person. And so I think that's great news and means that, what we're doing now really seems to work. All right. That I'll turn it over to Dr. Nathan to talk about medication options.
So there's a range of options for these emotional symptoms that we've sort of talked about, the cognitive, mood, anxiety, and so forth. I am a psychiatrist, so obviously I think a lot about sort of the typical psychiatric medications, which are antidepressants most often, but they're certainly not the only treatment, as Dr. Schiller alluded to, for these symptoms. But just to kind of start with our antidepressants, so these are the selective or the serotonin reuptake inhibitors or serotonin norepinephrine reuptake inhibitors. Those are just two different neurotransmitters that we think are involved in mood. These are kind of common antidepressants that you may have actually heard about. So these are the sertralines or Zolofts, Prozac or fluoxetine, Effexor, venlafaxine is a common one that people talk about with menopause. So these medications work really by targeting that feeling on edge, that irritability, low mood, low energy, and so forth. They have the added benefit of also being helpful for hot flashes. And I just want to kind of highlight this because these are an option if someone can't take or doesn't want to take, for a variety of reasons, hormones. They can be a really good, effective option and have been studied for these symptoms. These are also medications that you don't necessarily have to see a psychiatrist for. Sometimes we can talk to our OBGYN practitioners, our primary care doctors, and so forth. So they are relatively accessible. Some women do have concerns about side effects, which are completely valid. And so I always encourage a discussion with whoever's prescribing it just to make sure it feels like a good fit for you. I would say kind of practically common side effects can be stomach upset, a little bit of headache, particularly in the beginning, usually goes away after someone takes these medicines for about a week or 10 days, and as you increase the dose. Benefits are, again, it does have that kind of dual purpose of treating mood as well as some of the common menopausal symptoms like hot flashes. Usually for the hot flash benefit, low doses are needed. So you don't necessarily need sort of that large dose. So that's one sort of good medication option. Then there's menopausal hormone therapy, which is most commonly estrogen therapy with progesterone if someone still has their uterus. And that's done to protect the uterus, which I think we'll talk a little bit more about in this lecture. But this can be in the form of a patch, most oftenly, as Dr. Schiller alluded to, but there's also oral, gel, and spray forms. There's a variety of forms out there, and they can be really effective at treating mood, hot flashes, or vasomotor symptoms. And some women who see some benefit in targeting some of the cognitive symptoms as well. There's different preparations that may be more or less helpful for those symptoms as well. And we can think a little bit more about that if that's of interest to the group. I will say also, sort of jumping back to the antidepressants, that sometimes because these medicines reduce irritability, which can impact, and anxiety, which can impact concentration, that we sometimes also see cognitive changes with those medicines as well. So there's sort of a range of options. We have on the right that there's also a variety of supplements out there that are sort of targeted for the treatment of menopausal symptoms. We've listed here black cohosh because it's the one that's probably been studied the most, not nearly as much as the other two classes of medications that I mentioned. But it does have a little bit of an evidence for the treatment of primarily hot flashes. I think sometimes the challenge is how to sort of access these supplements and, if you know much about what they're mixed with, how they're compounded and so forth. So that is something to consider. And even if it's not prescribed, I always encourage people to share with their primary care doctors, GYNs and so forth, that they're taking them because they may interact with some of their other medications. And we just want to be careful. I will say there's a whole host of other supplements that are out there that are marketed towards women who are going through menopause. And in general, there's not quite as much data for their use. It doesn't mean that they're harmful necessarily, but it's just always worth kind of talking with your team just to make sure they think it makes sense to continue to take it or not.
I want to also add a couple things. So related to supplements, they're not FDA regulated. And so the amount that you're getting in the supplement may vary from bottle to bottle and also across the different brands, despite what they say on the label. So that's one thing to keep in mind is to try different, like if you wanted to try black cohosh, you might try different brands. If you find that one is not as effective as another, it may be because of variation in the actual amount of black cohosh that you're getting. And then if you have any side effects, to stop taking it right away, because again, because it's not FDA regulated, there can be other things added to it, or the dose may be very different than what the label suggests. And some people do have negative outcomes associated with side effects from supplements. And then in terms of menopause hormone therapy, in the interest of time, I cut out some of those other slides that Margo was thinking about. So I just wanted to address the safety of hormone therapies a little bit, and to think about folks with and without a uterus. So for menopausal hormone therapy, most people are good candidates for it, despite what you may have heard in the media. A lot of research has come out over the past 20 years to suggest that it is pretty safe and effective. It is the most effective treatment for hot flashes that we have. And as I showed you earlier, we do see big effects on mood as well. So for people with a uterus, hormones are prescribed, both estrogen together with a form of progesterone. And the addition of the progesterone is important to protect the uterus. So the progesterone prevents the lining of the uterus from building up over time, which can contribute to uterine cancer. So that's why it's important, if you are taking hormone replacement or hormone therapy, to have both estrogen and progesterone if you have a uterus. And if you have had a hysterectomy, meaning you no longer have a uterus, you can just take estrogen alone. And the active component, the part that seems to influence mood, is the estrogen. And there is another medication made by Pfizer called Duovy. And Kate's our program manager who's attending in the background here. Kate can put the spelling of that medication in the chat for people who are interested. But that medication combines estrogen with another kind of medication that blocks estrogen receptors in the uterus and breast tissue, such that the drug does not cause that the lining of the uterus to build up. And so you can just take estrogen alone if you take that medication called Duovy. It's a little bit more expensive, but if you're sensitive to progesterone, meaning that taking progesterone causes negative impact on your mood, Duovy can be a good option, because it means that you can just take the active component, the estrogen, that is likely to be beneficial to your mood. Anything to add there, Dr. Nathan?
The only other thing I might add is there's a lot of options with hormones. So for some of the progesterone containing intrauterine devices, or IUDs, sometimes they can be used with the estrogen medications as well. So that's like the Mirena and the Skyla and the Kylena. I think the first step in all of this is, talking with the doctor so you can sort of find out the menu of options and then talk about the pros and cons of each of them. I always encourage people, even if they're not sure which route they want to go, that just getting information can be a really good first step, and talking with someone that you trust about these potential options. I just want to, I see that someone mentioned progesterone causing mood symptoms, and I think this might actually be a reasonable place to talk about this, Dr. Schiller, if that's okay. So, um, women have sensitivities to different hormones. So there are some women that are sensitive to progesterone and progesterone containing medications. Sometimes the progesterone supplementation that's used along with the estrogen, but I will say sometimes progesterone is sort of given off label in other sort of settings as well. And I think that's why it's really good to know about these alternatives with Duovi, as well as the IUD as being another option if estrogen is of interest. But the short answer is yes, I think there's a lot to be learned there, and we don't totally know sort of why that is, because interestingly, some of the newer medicines that we think are helpful for hormonally related mood symptoms are actually progesterone derivatives. So we have a lot to kind of learn here, but the kind of like short answer is that yes, in some women, they can cause mood symptoms. I don't know, Crystal, if you want to add something.
Yeah, in our studies, we see that progesterone is either mood neutral, meaning that it doesn't increase mood symptoms, or it's negative, meaning that in some people who take progesterone, they feel worse mood wise, and the symptoms tend to be more related to like sadness, fatigue. Progesterone tends to have like a fatiguing kind of sedating effect on some people. And so if progesterone is part of your regimen, I would recommend taking it in the evening, because the sedative effects of the medication may help you sleep better. And to talk to your doctor about taking the lowest dose possible of progesterone to protect your uterus, but hopefully have less impact on mood. The studies that Margo was talking about related to progesterone derivatives, those medications seem to work differently than just giving women progesterone. So in those medications that have been approved for the treatment of postpartum depression include brexanolone and zuranolone. They seem to have beneficial mood effects, even though giving that same population progesterone causes negative mood impact. So as Margo said, there's a lot to be sorted through there. I do also want to say that there are some folks out there who claim to be experts in menopause treatment. They are advocating the use of progesterone and prescribe it through compounding pharmacies. They're calling it bioidentical hormone therapy or bioidentical progesterone. And there's no evidence to suggest that it actually is beneficial. And because it's made in a compounding pharmacy, it's not FDA regulated and it's really expensive. The hormone replacement therapy or menopausal hormone therapy that Dr. Nathan was prescribing has been around for ages, and insurance covers it. So it's pretty affordable to people. Duovi is the exception to that. It's a newer medication. It is FDA approved, but it's more expensive because Pfizer still has the patent on that medication. And so part of the reason for us doing this seminar series is to make sure that you all have that information, because as someone put in the chat at the beginning, there's so much misinformation out there because people are trying to make money off of you all. And so we wanted you to have that information coming out of today. All right.
So we've sort of gone through behavioral approaches, medication approaches to managing some of these symptoms, in particular hot flashes, but they're not the only strategy that we have. There's also some changes that we can make. Some are easier than others in our day-to-day. And again, some of these may or may not be feasible, so just keep that in mind. But for some women, it can be helpful to keep a journal. Sometimes we notice that like certain foods, particularly spicy foods, can actually trigger hot flashes, and we can kind of like keeping a migraine diary start to identify that. there is some good data that reducing caffeine and alcohol actually can be associated with hot flash frequency reducing over time. For some women, this is easier said than done, but again, just kind of worth keeping in mind or thinking about like the timing of our caffeine. For example, if you limit it to the morning, it preserves the night and so forth. Exercise, interestingly, definitely has some really good data here. And it's, sometimes people ask what's the kind of frequency or amount of exercise I need to do to get the benefit. It's a little bit variable, but here I would sort of say something that's like 20 or 30 minutes, at least several times a week, where you're getting your heart rate up, and ideally, 4 or so times per week. And then dressing in layers. So at night, a lot of women will sort of describe that they like wake up drenched, basically. So thinking about kind of cool layers, fans, air conditioning units. There's actually cooling blankets and cooling pillows that are made that can be really helpful here, and sort of help like 10% of these symptoms. So there's a good number of things out there that can be useful as well, just in your day-to-day.
Great. All right. So if you have, we're going to address all the questions in the chat and the Q&A, but if you are thinking that it would be helpful to reach out to somebody about some of these symptoms, there are people out in the community that are, providing treatments. We also have, as I mentioned at the outset, this women's midlife mood disorders clinic, where we treat people going through the menopause transition, and we provide specialized consultations, including reproductive and psychiatric evaluation, recommendations for managing hormonally associated mood and anxiety symptoms. Our therapy team provides short-term behavioral interventions. Dr. Zahn and Dr. Schiff can prescribe hormones, and we work together as a team to help create individualized treatment plans based on an individual's history and what's worked well for them in the past, their current symptoms, and what we think might be most effective. So you can learn more by going to our website or just calling UNC Hospital, and there you can get an appointment. Also, if we've had people join these sessions who are interested in doing training in this area, and I think it's also heartwarming sometimes for patients to know that we are training more and more people to do this work, because there are a lot of people out there who don't know what they're doing and are just unaware of some of these things. And so if you're interested in training in this area, we have training programs available to college students, psychiatrists, people training to be psychologists, and postdoctoral fellows as well. So lots of training opportunities for folks. All right, so next I want to move on to the Q&A. And I'm going to stop sharing my slides now. Okay, and let's see. We had questions come in through the Q&A and through the chat. So I'm going to start with a Q&A, and then we'll go over to the chat. And if more questions come up, go ahead and keep adding them. One question is trouble coming up with words a common way of experiencing cognitive concerns? I have some ideas about that, but Dr. Nathan, do you want to go first?
Sure. So the short answer is yes. There's sort of a range of like cognitive symptoms that can happen with menopause. I sometimes describe it as just feeling like you're not as sharp. It just like takes you longer to think about words. It takes you longer to do your work. It just feels like we're moving like a little bit slower. It's harder to kind of use those tools that we commonly have. And sometimes these symptoms are not as easily like quantifiable. They don't necessarily fit in a nice box of like ADHD or another sort of cognitive disorder. There's just kind of this general sense of like cognitive impact. so very common, and yes, word finding can definitely be a part of that, and some of the treatments we mentioned, and we can talk about that in greater detail in a minute if that's helpful, but do actually improve those symptoms.
Great. Yeah, and we're seeing that like in the research realm, the specific symptom that is most commonly seen that begins during the menopause transition and actually resolves after a woman gets through menopause is called verbal working memory. So it's the ability to hold words in your mind as you're doing something and then use them or manipulate them, so, which means that like while you're thinking and talking at the same time, which is what I'm doing now, that ability changes during the transition to menopause. And so there are treatments. There was another question, and maybe we can address this, Margo, of potential treatments for this symptom. There are non-pharmacologic as well as pharmacologic treatments for this brain fog or cognitive symptom. So just I'll start with the non-pharmacologic treatments first, and then Margo, you can weigh in on the pharmacologic side. So their exercise actually is something that has been shown to improve cognition across the lifespan. And so doing engaging in regular cardiovascular exercise improves cognitive ability. So that might be something to consider. And then there are both hormone related and non-hormone related treatments. So over to you, Margo.
Yeah, so I think there's sort of several buckets that I think about. So really the first question is actually kind of what's associated with the cognitive or the attention symptoms. So just making sure that like anxiety isn't in the picture, mood symptoms. Sleep is really a common thing here. So if someone says that they're having trouble concentrating with word finding and so forth, the first question I actually usually ask is, well, how are you sleeping? Are you sleeping in 2-hour chunks at night? Because that can definitely impact kind of how we function cognitively. So, and then sort of gearing some of those treatment options to what is the sort of problem that we're trying to address. Sometimes the antidepressants are actually helpful for those cognitive symptoms because they address anxiety and irritability and so forth, and help with promote sleep. There's a little bit of data supporting the use of stimulants, particularly at low doses, or medications that you may have heard of, like modafinil or armodafinil. So sometimes those medications are used a little bit off-label in the treatment of these symptoms. And then thinking a little bit about hormones. So estrogen supplementation does have some good data supporting its promotion of cognitive abilities. Sometimes thinking a little bit about whether that in combination with different testosterone preparations can be helpful as well. I will sort of say the caveat there that when we're thinking about testosterone, there are potential for side effects like blood pressure changes and so forth. So I do encourage kind of talking with your gynecologist and trying to pursue the kind of treatments that are given in typical medical settings rather than the bioidentical industry that Crystal mentioned, where there can sometimes be some side effects that can be pretty scary, particularly the blood pressure changes. So again, there's sort of several different ways to approach that, and it is definitely treatable.
Great, thanks. I'm seeing a question here about, are there any studies about hormones where someone is dealing with both postpartum / breastfeeding hormones and perimenopause? And this is a great question because more and more Dr. Nathan and I are finding that people are perinatal, so having given birth and then breastfeeding and then entering menopause right after that or around that time. And I think there haven't been really any studies of this yet, but when we were talking earlier about the hormonal roller coaster of the perimenopause, I think that's just amplified by having a baby in around that time period. And so it's just, the hormones of pregnancy are the hormonal changes of pregnancy are really high in magnitude, and then you have a really dramatic drop off in hormone levels. And then if that's combined with going into perimenopause right after that, then it just sort of amplifies the rapid changes in hormones day to day. And I think that can, for women who are sensitive to changes in hormones, that can really turn up the volume on those mood and emotional changes that people are experiencing. Anything to add there?
No, I think just sort of completing the picture that oftentimes this kind of concept of hormone sensitivity can be across reproductive changes. So it's not even always just pregnancy and postpartum, but like when your period comes back after having a baby, or when you're stopping breastfeeding, if you're breastfeeding. Also just around periods in general, if someone's premenopausal, even if they haven't had a pregnancy previously. So we tend to see these things, not always, but cluster. And the way we think about each of them is similar, but there are some differences. So
Yeah, and in our studies, we're seeing a lot of people with mood symptoms in the transition to menopause who have had prior experiences with postpartum depression or mood symptoms with their periods, PMS or premenstrual dysphoric disorder. And so, or even earlier in the transition through adolescence, having mood symptoms with that. So as Margo said, sometimes these things go together, and at least in our research setting, we're seeing that quite a bit. How are the hormones in birth control pills or IUDs like Mirena different than menopause hormone therapy? Do you want to answer that one?
Sure. So they're slightly different in the hormones that are present and also in what they do to our hormones. So the intrauterine device, or IUD, there's some actually that are non-hormonal. So that's historically the copper IUD. And then the ones that are hormonal are most often, or are pretty much exclusively, progesterone based. So that's like the Mirena and the Kyleena and the Skyla. They don't involve estrogen. They work essentially by sort of like thinning the lining of the uterus so much that you can't support a pregnancy. They don't necessarily suppress ovulation, although in some women, they don't have a menstrual marker or a monthly period. And that's most often because the lining of the uterus is so thin that you just can't have a bleed because of that. So that's kind of how the IUDs work. The combined birth control pills are a little bit different. So there's some pills that are progesterone only, sometimes called the mini pill or norethindrone. And then there's the combined pills, which have usually that progestin as well as ethinyl estradiol, which is a type of estrogen that Crystal had, I think, mentioned earlier. They work by suppressing ovulation. So essentially, in a menstrual period, you have a period, your estrogen climbs, you ovulate, and then it kind of crashes almost in like this roller coaster down to the next period. And what the birth control pills do is, instead of your brain seeing these huge sort of spikes and drops in hormone fluctuations, it kind of makes them more like rolling hills instead of mountains, more or less. So that's a little bit different than menopausal hormone therapy, which literally sort of adds back estrogen and raises the floor on the amount of estrogen that's kind of circulating on your body. So women can take menopausal hormone therapy and actually still ovulate and still make some of their own estrogen as well. So it's a little bit of a different mechanism. And I also realize that this is complicated, thinking about these different types of medications, and there can be a lot of jargon, and sometimes it's confusing how some things work for some issues and not for others. So if there's any follow-up questions to that, feel free to kind of put them in the chat or in the Q&A. Crystal, anything you want to add to that?
I was just going to say one other thing, which is that in the combined oral contraceptives, the hormone dose is generally a bit higher than what you would have in menopause hormone therapy. And so at some point, physicians often will tell people to switch from an oral contraceptive to menopause hormone therapy just to lower that dose. All right. Another question was about ways to address weight gain. We're going to have a whole session devoted to that in the beginning of February. So we will spend a lot more time then. But it is true that during the transition to menopause, people often gain weight, and the body composition, so the amount of fat relative to bone and muscle, also changes, and that can be distressing. And then the distribution of weight on the body can also change. And so that can make your clothes feel and fit differently, even though your weight may stay the same. And so this is a major topic, as someone else put in the chat. Like, it's a huge industry. There are companies trying to sell you all sorts of things to prevent weight gain and manage weight gain. So in our clinic, we manage it behaviorally. In other places, like an endocrinology clinic, they might prescribe medications for it. There was an article just last week in the New York Times about the use of Ozempic and new weight loss medications for managing weight gain in the menopause transition. And so I think this is a space where more and more research and attention will be focused. And one of our colleagues on the seminar series focuses on kinesiology, so like how your body works, and nutrition. And so she'll be part of the discussion in February, as will hopefully an endocrinologist on our team who works with people around weight gain and metabolic concerns like diabetes. So go ahead, Margo.
Yeah, the only other thing I would add is there's also some good data that when our sleep is more disrupted, there's more difficulty with not only weight gain, but difficulty losing weight that we've gained. So sometimes, again, thinking about tackling problems from other angles, sometimes the name of the game with menopause, and sleep is an area where if you can improve it, you can actually have really nice positive effects in other aspects of your life.
Yeah, that's a great point. All right. Which hormones are recommended for HRT if you have one ovary left after hysterectomy? My impression is that the recommendations are exactly the same, whether you have one ovary or two. Anything to add to that?
No, I think that's my understanding as well.
Okay. Yeah, so if I had a hysterectomy years ago but still have one ovary, is it possible that I can still get period symptoms in my mid-60s, such as spotting? Also, I used to take HRT for a few years, but my doctor told me to stop after a few years due to risk of breast cancer. What's the recommended length of time for HRT? And you still had a hysterectomy and still have one ovary left. I think we just address that question in the last one. I think the recommendations for one ovary versus two is the same. And it is, some people continue to have perimenopause, so like spotting, periods for a very long time. So the average length of perimenopause it really has a tremendous range. For some people, it's really short and just, a year or so. And for others, it can be like 14 years. And so I don't think that there is one right way or one window that we can really say, like, after this amount of time, you certainly wouldn't still be having periods. However, if you're still spotting into your mid-60s, I'd recommend talking to a doctor about that. And then newer research suggests that there is no reason to stop hormone therapy at a certain point. There's no safety data to suggest it's unsafe to continue taking hormone therapies as long as you remain healthy. That is sort of an outdated idea. This lowest dose for the least amount of time, I think, has really been debunked.
Yeah, I would agree with that as well.
I will say, though, that if you've gone for a long time without a period and you have not taken hormone replacement therapy, there is data to suggest that starting hormone therapy after the age of 65 can have detrimental effects, both on mood and on physical health. So the rule of thumb is to start hormones earlier rather than later, and that seems to lead to the best outcomes.
Yeah. Yeah, part of why the recommendation has shifted a little bit to continue the hormones if started at an appropriate time is because we know about 30 to 40% of women will have some fairly severe menopausal symptoms like years after their last period. So those menopausal symptoms, even if someone is, well into the post-menopause, can continue for quite a long time.
Does anyone in the mood disorder clinic specialize in disordered eating or eating disorder in addition to perimenopause? We've done a little bit of research on this, and we can manage some disordered eating in our menopause clinic, and as well in consultation with our colleagues in the Center for Excellence in Eating Disorders. And then some of us specialize in both. And so, it's possible that we could get you connected to the right person who could manage both sets of symptoms if both are really prominent and problematic. What is the recommended bedroom temperature to sleep in to help mitigate hot flashes and night sweats? I think it's lower than what I would expect. It's like 60 to 65 or something is what I've read. What about you, Margo?
I was going to say 64 is sort of a number that I've heard, so that's pretty consistent. I think the number you need to feel cool, and there's some air conditioning units that have a limit to that, but it is fairly low.
All right. Now I'm going to move over. Those are all our Q&A questions. I'm going to see if I can move over to the chat now. Okay. Okay. I'm wondering about the slowing down of executive functioning. Are there over-the-counter supplements for that? We have talked about the behavioral and medication treatments for, cognitive slowing. For executive function in particular, as Margo mentioned, there have been some studies using stimulant medications to good effect, both for verbal working memory and improving executive functioning. But in terms of over-the-counter supplements, I'm not aware of any that have shown positive benefit.
Yeah, I don't know that there's any that I could say sort of definitively could be helpful. There's many things that are marketed for it. If the interest is in things that are like non-medication, there are definitely some good strategies. The behavioral strategies that Crystal mentioned really can make a world of difference.
Right. Can progesterone cause depression in some people? I just started Duovi for this reason. We've addressed that. So yes, that's true. And for some people, Duovi is a really great option for that reason. Okay, we talked about cognitive function. Yeah, I just heard that menopause is a $16.1 billion industry currently, many diets and supplements, as well as that bioidentical hormone thing that I mentioned. So yes, that is true. Many people are trying to capitalize on this period of time. And I think in large part, it's due to the fact that there has been relatively little research that's been devoted to this in the last 20 years. There is like a big gap in people's knowledge of what could be helpful here, which is a big reason for us doing this seminar series, to give you the information that you need to make good decisions about how to manage these symptoms, because you may know more than your doctor. And I think in medical education, menopause and its treatment have not been well emphasized, despite the fact that 50% of the population will go through menopause. So one other place that I want to highlight where you can get high quality information rather than just Googling questions is to go to menopause.org. That's the website of the Menopause Society, and the content there is vetted by doctors and scientists. So there you can feel relatively confident about the information that you're getting. Do you need progesterone after an ablation that completely stopped all bleeding? Yes. So if you still have a uterus, even if you've had an ablation, you still need to take progesterone in combination with estrogen in hormone replacement therapy, or you could take Duovi. Okay. I think we have addressed all the questions now with time to spare. So thank you all for attending today. If you wouldn't mind, before you head out, could you put in the chat one thing that you're taking away from this session today? And then we're also going to send you a quick survey to complete after this so that we can continue to iterate and improve as we go forward. As I mentioned, we have lots of different kinds of events planned. Things as diverse as like having a group like panel with physicians. We have plans for doing a cooking class, plans for doing a group exercise class. So we're really interested in hearing from you about things that you're wanting to know about and ways that we can help. So thank you so much for sticking with us today and attending, and we look forward to seeing you at the next one. Kate, can you put the information for the next session in the chat? Or just unmute yourself and tell people.
Yes, so our next session is going to be Friday, February 1st at noon. And so it most likely will be in some virtual capacity, but we're still working out the specific details, and we'll send out an email with information on that following the session.
Great. Glad this was helpful. All right. I think we can go ahead and wrap up now. Thanks, everybody. Take good care.